Good afternoon, everyone, and welcome to We See You HIV Basics, presented by the EHE team here at Lifelines. We have the pleasure of having S.E.A. Thorne with us, as well as Ms. Tamika Wright. I'm going to let them introduce themselves. S.E.A. is the co-executive director and director of prevention and outreach at AIDS Alabama South, and Tamika Wright is our Mobile County Prevention Program Manager from ADPH. So S.E.A. will get started with you, and then Tamika will let you introduce yourself as well.
Absolutely. Good afternoon, everyone. Thank you so much, Lifelines, for having me. I'm elated to be here. As Chanel mentioned, my name is S.E.A. Thorne, co-executive director here at AIDS Alabama South. I oversee our prevention, outreach, and education department, psychosocial services, our sexual health clinic, and our 340B pharmacy and relationships. Currently, right now, I'm studying to get my master's in public health. I will graduate in August, and then I will go right into a doctor of public health program. I've been in this work for going on 5 years now. Prior to that, I was a high school dance education and health sciences teacher at BC Rain High School here in Mobile. And personally, I've been living with HIV for 12 years.
Good afternoon, everyone. My name is Tamika Wright. I'm the program manager for the HIV department with the Alabama Department of Public Health here in Mobile County. Good luck, S.E.A., on your master's. I also partner with S.E.A. as well as Lifeline and any other CBOs and ASOs within the Mobile County area.
I'm sorry, I keep muting myself. Yes, they have both been great community partners and have been very instrumental in the work that's being done in the community. We also have the pleasure of S.E.A. having a presentation for us today with some basic HIV information and some other insights into the world of HIV. So I'm going to turn it over to him and let him do what he does best.
Awesome. Thank you. It's been a while since I moved into this position. I haven't been able to do an HIV 101. I'm so excited. All right. Chanel, could you allow me to share my screen, please? I'm going to try this out. Hopefully it works. All right. Can y'all see the correct screen? Good. Awesome. Okie dokie. All right. So we're going to get going with some HIV 101. Chanel, do I have a specific time limit that I need to stick to? Because she can talk.
You're good until 2.
Sweet. I will try not to go that long. All right. So what is HIV? So HIV, this is the virus that does cause or lead to AIDS if it is left untreated. HIV stands for human immunodeficiency virus. And so breaking that down, human, that means it can only be passed from human to human interaction, and very specific interactions at that, which we'll get into. Immunodeficiency, this means that this virus gets into our system and it breaks down our CD4 plus T cell counts. Our CD4 plus T cells are our white blood cells. And so our white blood cells are what keep our immune system strong and healthy. So by HIV entering those cells, breaking them down and restructuring them into a viral cell, our immune system inevitably becomes less than efficient, would be the best way to put that. And then what we know about viruses are that they need a host. And so therefore, for HIV, the human becomes the host and they can self-replicate. So you need one little small portion of this virus and then it can get into the system, attack those CD4 plus T cells, and then continue to replicate inside of that person's body. So as I mentioned, HIV does damage the person's body by destroying those CD4 plus T cells. And as of right now, we do not have a cure, even though we've heard of people being cured so far as what we know from HIV. Those were very specific instances of individuals that were seeking cancer treatment outside of the United States. And because of the specific treatment that they received, their HIV was simultaneously cured along with their cancer being put into remission. So very, very specific, very odd occurrences, does not happen elsewhere. However, with proper medical care, HIV can be completely controlled and someone can live a long, healthy, and happy life with HIV and never worry about passing it along to anyone, including their sexual partners, which we will get to. So what is AIDS? As I mentioned before, AIDS occurs if HIV goes untreated. AIDS stands for Acquired Immunodeficiency Syndrome, and it is the final stage of an HIV infection. I don't love the word infection, but whenever we're talking medical terminology, it is most appropriate to use HIV infection. But we never want to refer to someone who is living with HIV as being infected, because that's very stigmatizing, and it can have a really detrimental effect to them, their health, and the community that surrounds them. The three stages of HIV are acute infection, and that's whenever someone initially becomes or acquires HIV. And if left untreated or undiagnosed during that time, that can lead to clinical latency. And so clinical latency is where HIV remains in the system, in the body, and it slowly reproduces over a longer period of time. And individuals can stay in the clinically latent stage of HIV for up to or past 10 years that we know of. If no treatment is administered during that time, then that person could potentially lead or eventually end up into what we know as having AIDS. So AIDS equates to a weakened immune system, because that's what HIV is doing that entire time of being left untreated, is breaking down those immune cells, those good cells. And therefore, that person is at a much higher risk of opportunistic infections and cancers, which could be extremely detrimental to their health and their body. So for someone to reach an AIDS diagnosis, the CD4 plus T cell count, which HIV has been breaking down this whole time and really diminishing this whole time, has to be less than 200, where a normal CD4 range would be somewhere in the 600 to 1200 range for a healthy or for someone who has not had or led to an AIDS diagnosis. So how do I know if HIV has progressed to an AIDS diagnosis? The only way to know that you have HIV is to get tested. And the CDC recommends that everyone between the ages of 13 and 69 get tested at least once in their lifetime. And we recommend continuous testing, especially for individuals that are at highest risk in our high risk categories, those that are sexually active, or those that have experienced very specific things that lead them to be at a higher risk of having HIV. Then mostly we recommend that they get tested every 3 months on a regularly occurring basis. However, the following are warning signs and symptoms that HIV may have progressed to AIDS. So I will say for HIV, not everyone experiences signs and symptoms. So, but if you do, it could present as like a thoracic rash. So a rash around your rib cage and upper chest area. Your lymph nodes could be swollen. You could have regular flu-like symptoms. For me, whenever I very first found out, I thought I had the flu for 2 weeks. And then I went in, I got some blood work, and he was like, well, your white blood cell count is super low. We need to do some more testing. So it's different for every single person. A lot of times what we see here in the agency whenever we're testing and people receive an HIV diagnosis is that they have had 0 symptoms whatsoever. However, if HIV is left untreated, some of the symptoms that are more appropriately related to an AIDS diagnosis would be rapid weight loss, a dry cough, recurring fever or profuse night sweats, unexplained fatigue, swollen lymph glands in the armpits, groin, and neck, diarrhea that may last for more than a week, white spots on the tongue, in the mouth, or in the throat, pneumonia, and memory loss. Now, that does not mean that because you are experiencing those signs and symptoms that you have HIV or that you have progressed to AIDS, because those can all be applied to 100,000 other illnesses or viruses, anything, literally. So testing is the key here. So what does HIV do to your immune system? So here on the left-hand side, we have a CD4 cell, a lymphocyte. And what happens up above, you see that prickly, spiky virus, which we can kind of relate that to the image that we've seen of COVID-19. And so what happens is it enters this cell by breaking through that cell membrane and entering into the cell and specifically targeting that cell nucleus and the genetic material that make up that cell for its specific function in the body. So once it enters that secondary membrane, HIV inserts its genetic material into that cell nucleus, and then we see what's known as a dormant state. And we have this 1 to 10 year period where HIV continuously reproduces with this new genetic material inside what used to be a healthy immune cell. And then HIV becomes active. It destroys the cell and it spreads even more widely. So how is HIV transmitted? HIV can be transmitted through blood, breast milk, vaginal fluids, semen, also pre-ejaculate, what people genuinely do not consider or think about, and anal fluid. So HIV is passed through unprotected sexual contact, essentially. And it can also be passed during pregnancy or from a mother to their child at any stage in the pregnancy, through childbirth or through breastfeeding, and also through injection drug use. We always recommend that individuals who are pregnant do get tested for HIV, because as long as they're put on treatment, and we'll learn here in a little bit, then they run no risk, zero risk of passing HIV along to their child. And as far as the injection needles are concerned, if someone who was living with HIV and was not on treatment used a needle and shared that needle with someone else, or left the needle on the countertop, or accidentally dropped it on the floor. And this doesn't have to be for recreational or abusive drugs. This could also be for injection drugs, such as for individuals who have diabetes or specific allergies. HIV can live in the shaft of that needle, the hard part of that needle, for up to 1 week that we know of. So as opposed to someone living with HIV and bleeding and it getting on the floor, within 1 minute, it's going to become oxygenated and break down. And so we have no worry or no risk of passing HIV along through that transmission method, but we still take precautions in cleaning that up. We wear our gloves, we use specific cleaning solutions and things like that, and we throw it away properly. However, we strongly suggest the use of clean needles, and if you cannot access those, then cleaning your needles properly. So as I mentioned, HIV is transmitted through condomless sexual activity, which can include anal sex. So inside of the anus, the epithelial tissue in there is a mucous membrane. And so this means that it's a very soft tissue that is easily torn, and it leads directly to the bloodstream. And so that is why we find that individuals who identify as gay men or men who have sex with men or who have anal sex are at a disproportionately higher risk of contracting HIV. Next is vaginal sex. The vagina is also a mucous membrane, and individuals with vaginas are typically the receptive partner or the receiving partner. And in either case, the receiving partner holds the higher risk of contracting HIV because of that mucous membrane. And individuals who have penises are at a high risk for transmission as well, if vaginal fluids do happen to enter through the urethral canal during penetration. We can also sometimes, very rarely, see HIV transmitted through oral sex. And oral sex involves oral contact with the penis, vagina, or the anus. And all of these areas have bodily fluids that may transmit HIV as well as mucous membranes. Although the risk is much lower during oral sex, the transmission may still occur. And so we do recommend active precautionary measures if you anticipate participating in oral sex. So furthermore, HIV can be transmitted from pregnant people to their child during childbirth. HIV is transmitted during childbirth when the child is born vaginally, not necessarily through a cesarean section. Prenatal care is highly recommended during the early stage of pregnancy, and also sharing needles and injection drug use equipment. Needles are injected into the body straight into the bloodstream. So that is a direct pathway for the virus to enter the system. We can also see HIV transmitted through breastfeeding. Breast milk is a bodily fluid, and that can hold or transmit the virus. And parents should not breastfeed if they are HIV positive. And also we can see HIV transmitted through blood transfusions. Blood carries HIV if it is present in the body. So how is HIV not transmitted? We cannot pass HIV along by hugging, shaking hands, sharing toilets, sharing dishes, or closed mouth, or what is known as social kissing with someone who is HIV positive. It is very rare to pass HIV through kissing from one person to another. Both individuals would have to have open sores and be actively bleeding. And typically we don't like to kiss each other whenever we have blood in our mouth. And if HIV were to enter your system and go down your digestive tract, typically the acidic fluids break it down and you do not have that high of a risk of being that way. It does not transmit through saliva, through spit, through sweat, tears, that is not mixed with blood of a person who is living with HIV. So regular saliva, tears if you're crying, sweat, you have zero risk. HIV cannot be transmitted by mosquitoes, ticks, or other blood-sucking insects. HIV cannot be passed through the air. So if you're in an elevator with someone who is living with HIV and you don't know it, and they happen to sneeze or cough, you run no risk of contracting HIV. Or just generally walking, through the store and breathing the same air as someone. Only certain bodily fluids from someone who is living with HIV, who is not on effective treatment, can be transmitted. So a big part about talking about HIV is talking about the stigma that surrounds HIV. And all of us in our work, we work daily to eliminate these stigmas, because due to stigma, we see very high rates of miseducation, lack of education, the spreading of myths about HIV, and we'll get into a little bit of those here in a little bit. And we kind of see this circle. So we have HIV and AIDS right in the center. And this circle is continuous because stigma is continuous until we learn to break that cycle. We educate ourselves, or we listen and we understand, and we share this information in our communities to get the proper information, the accurate, medically accurate information out there for people to understand. So stigma is the disapproval of or discrimination against someone based on perceivable characteristics that serve to distinguish them from other people. So basically, it's discriminating against someone for one specific aspect of who they are or what makes them who they are. That separates them from what we know as the socially constructed normal person. Different types of stigma are commonly related to culture, gender, race, intelligence, and health. And in this case, fear and discrimination fuel the fire against people living with HIV. So we see, everyone has a fear of HIV, right? Because we imagine HIV as we know it from the 80s and the 90s, when it was only the gay man's disease, and individuals, they didn't have accurate treatment for it at that time. Individuals were dying. Their nurses were afraid to touch them or to be in the room with them. Their family members were afraid to share utensils and a household with them, or a bed. And so that fear has kind of been effervescent. It's been generational ever since because of the lack of education. And so that fear leads to the stigma or the thought that, this is what HIV is. And then holding that stigma, inherently, we hold internal and subconscious, unconscious biases that lead to discrimination. the way that we talk about HIV, the way that we talk about our family members or people we know who are living with HIV. Aside from that, and after that, it then leads to silence. People typically shut down, either those living with HIV who have now been stigmatized and placed into this bubble of who and what they are, or from those people that were doing those stigmatizing acts and the discriminating, who then, kind of shut down because that's the end of their cycle as they think of it. They've now shared their feelings and their thoughts, their negative thoughts about that person. And then that silence, because individuals do not seek to go outside of what they have been taught inside of their families and communities to learn more and learn the accurate information, then leads to ignorance, continued ignorance about the subject, and then the cycle continues. So eliminating stigma will take a lot of things, but what we know what will eliminate stigma is changing the way that we talk about HIV. So instead of saying something like, are you clean, whenever we're talking about STIs, sexually transmitted infections or diseases, we could say, are you HIV or STI negative? Instead of saying high risk people or high risk groups, which a lot of us in this work still use because it is public health terminology, we could say high risk behaviors or highly affected communities. And instead of saying an AIDS patient or AIDS in general, we could say HIV or HIV and AIDS or a person living with HIV. And instead of saying catch AIDS or HIV infection, we should say transmit HIV or an HIV diagnosis. U equals U. This is my favorite part. So U equals U stands for undetectable equals untransmittable. Undetectable means that modern medical tests cannot find HIV in a person's blood. It does not mean that HIV is cured. It means that it is not detectable. A viral load test, which is a lab test that measures the number of HIV particles or copies in a milliliter of your blood, is performed. If the test does not detect any copies of HIV, then you are considered undetectable. Undetectable status is reached by proper adherence to ART, also known as antiretroviral therapy, which is the treatment for HIV. And a person with an undetectable viral load cannot transmit HIV to another person. So I want to say that again. Someone that is living with HIV, that is on effective treatment, meaning that they are medically adherent. They are seeing their physician, they are going to their appointments, they are getting their regulated blood work, they are taking their medicine as prescribed, and they have reached an undetectable viral load. So the viral load has dropped, which has allowed the CD4 plus T cell count or our immune system to increase. Then those individuals cannot pass HIV along to anyone under any circumstance. So now we're going to get into some statistics about HIV. Most of the new HIV diagnoses among women were attributed to heterosexual contact. So we see here that there were 85% for the heterosexual contact of HIV transmission. There were 6,130 individuals who had contracted HIV. The other lesser percentage, 15%, was transmission through injection drug use, or 1,049 individuals. And then other, or an indeterminate factor, we aren't really sure how they contracted HIV, we do see 1%. New HIV diagnoses among women by race and ethnicity in the United States and dependent areas. So we know for a fact, it is truth, that African American and Black individuals, men and women, gay or straight, it does not matter, are at the highest risk and are most disproportionately affected by HIV. This is due to a multitude of reasons, but we can pretty much dwindle that down to it being due to health disparities, the system working against the people. These individuals have perpetually been isolated into communities that are far outside the inner circles of a more higher socioeconomic status community where there's easier access to healthcare and education and services and resources. And so they were intentionally placed into these corners of our communities where they can't reach that. They don't have the transportation or whatever other factors may be barriers to them receiving testing and care and treatment. And this has been perpetual. And this has been something that all of our organizations continuously work against and on, so that we can lift up the voices of African American and Black individuals, and so that we can share the reality that these individuals and communities face, so that we can fight against HIV. The CDC actually states that 1 in 2 African American and Black gay and bisexual men who have sex with men will face an HIV diagnosis in their lifetime. And it literally gives me chills right now. 1 in 2, 50%. And that is absolutely ridiculous. And it is something that we can put a stop to. Their white counterparts account for 21% of HIV diagnoses, which you can see is much less. And then Hispanic and Latina individuals, 18%, multiple races, 2%, Asian, 1%, American Indian, Alaskan Native, less than 1%, and Native Hawaiian or other Pacific Islander, less than 1%. New HIV diagnoses among women by age in the United States and dependent areas. So from ages 13 to 14, which we recognize as youth or the youth age, there is 14% of those individuals during this time frame, 2018, 14% of that population. 25 to 34 accounted for 27%, 35 to 44 accounted to 24%, 45 to 54, 20%, and 55 and older, 16%. These numbers aren't very far apart from each other, but we do see that ages 25 to 34 for women do run the highest risk of contracting HIV. So at the end of 2016, an estimated 1.1 million people had HIV. Of those, 258,000 were women. It is important for women to know their HIV status so that they can take the medicine to treat HIV if they happen to have the virus. Taking HIV medicine every day, as I've mentioned before, can make the viral load undetectable. And women who get and keep an undetectable viral load, or stay virally suppressed is another way to say that, have effectively no risk of transmitting HIV to HIV negative sexual partners. These images were gathered from the CDC, in case anybody is interested in looking them up. When compared to people overall with HIV, women have about the same viral suppression rates, but more work is needed to increase these rates. In 2016, for every 100 women with HIV, 66 received some HIV care. So 66 out of 100 women living with HIV received some HIV care. That's only a little bit over half. 51 were retained in care. So literally 1% over half of these individuals were medically adherent. And then 53% achieved viral suppression. So only half of those individuals living with HIV achieved an undetectable viral load, meaning that they cannot pass that along, which means that the other half were not virally suppressed and still run the risk of transmitting HIV. For comparison, for every 100 people overall with HIV, 64 received some HIV care, 49 were retained in care, and 53 were virally suppressed. In 2018, 37,968 people received an HIV diagnosis in the United States. About 14% of people living with HIV, or 1 in every 7, did not know that they had HIV. And that is why we suggest and encourage HIV testing so much. An estimated 1.2 million people in the United States had HIV at the end of 2018. About 37.9 million people were living with HIV around the entire world. HIV diagnoses are not evenly distributed across states and regions, and the highest rates of new diagnosis continue to occur right here in the South. So specific statistics here for Alabama. Number of people living with HIV diagnosed with HIV in 2016 for our state was 12,643 individuals. People living with HIV per 100,000 people was 310 for every 100,000. The percent of people living with HIV by sex was 81% male and 19% female. And the percent of people living with HIV by race And this is where we begin to really put those numbers into reality and see the disparity. Is we're essentially at 64% African-American and Black, 3% Hispanic and Latinx, and 27% white. Percent of people living with HIV by age. So 5.2% of individuals who were aged 13 to 24 were living with HIV, 19.2% for 25 to 34, 21.1% for 35 to 44, 28.4% to 45 to 54, and 26 for those aged 55 and older. So at this point in time, we do have some new numbers, and I do need to update this. It won't update that much, but the highest risk age group in total would be ages 45 to 54, which we typically don't think would be the reality. So how is HIV treated? Many regimens or prescriptions given treatment for HIV, they are cocktails, they're mixes that contain all necessary components into one pill. And so people living with HIV work with a healthcare provider to choose a regimen that works most successfully for them. The initial HIV regimens include 3 HIV medicines from 2 or more drug classes. And here we see 1, 2, 3, 4, 5, 6, 7 different bottles. And those are the different drug classes that we have. To put treatment to a face or a voice or a reality, I can talk about my treatment for a little bit. So whenever I was very first diagnosed with HIV, I was 19. I was a freshman at the University of Alabama. I was walking around the quad, living my life, being gay and happy and thinking everything was great. And then I received a call from my provider, and they were like, you know, we need you to come home. We found some abnormalities in your lab tests. And this was about 3 months after I had gotten the initial blood work where they said that my white blood cell count was low. So of course I was like, I live in Tuscaloosa. I'm a student. I have no job. I don't have a car. I'm not going to be able to get home. You need to tell me now. And so he was like, well, we typically don't do this, but I'll tell you. Okay, well, I thought my life ended. I was young, I was dumb, and we didn't have this education that we have about HIV now back then. At that point in time, there was not U equals U, and we didn't have the preventative methods that we have now, which I'll get into in a second. Due to some disparities in the healthcare system at that point in time, it took about 3 months before I was able to actually see a provider. And actually, I was seen at Cahaba Medical Center, which is relationally to us a very similar organization. So I like to say that my work in this field of work has come full circle, because at one point I was on the receiving end of those resources, and now I'm helping lead an agency and a movement in our community to provide those resources. It took another 3 months for me to actually get the medicine, because patient assistance programs and insurance issues weren't as easy back then. I started on a pill called Atripla, which had its very own drug class, mix of cocktail of drug classes. For me personally, it had some really bad side effects. I had very vivid dreams. I would feel kind of drunk. And I don't say that to scare anybody, because the reality is that all medicines impact each person differently. So what my experience is may not be another person's experience with living with HIV. I was on that medicine for 3 to 4 years, and then I talked to my provider. I couldn't do it anymore. I wanted to try something else. And there was this new pill at the time, and it was called Triumec. And it was a mix of different regimens. And that one worked wonders. It was a bit of a horse pill. It was quite large. But most recently, we have really, really, truly progressed in medical treatment for HIV. And we have injections now. And these injections are once every month or once every 2 months. And so now I'm taking Cabenuva, and this is in a completely different set. So Cabenuva consists of cabotegravir and rilpivirine. And so it's 1 shot of each in the left gluteal muscle and the right gluteal muscle. And I get that every 2 months. So I went from having a very heavy pill burden to not talking about my HIV openly or comfortably with people at that point in time, being worried to go on adventures and go out of town with friends or my partners at that time and take a bottle with me and then run the risk of having to explain what that is. Not that you have to explain yourself to anybody, but people are nosy and ask. And now that all has been eliminated, and I just go see my provider once every 2 months. I get 2 injections and I am maintaining viral suppression. So the reality is that treatment works, and it's grown tremendously and in insurmountable ways. And there's always more to learn every single day about HIV treatment. So ways to prevent HIV and their effectiveness. So we can practice abstinence. And I like to say that abstinence is not for everyone, and that is okay. None of these options are for everyone. But abstinence, or abstaining from or not participating in sexual acts, is 100% effective at preventing HIV. Condoms. Condoms are 70 to 90% effective. And this is a little scary because a lot of people rely on condoms as a prevention method. And we still push condoms because when they're used properly, then they are very, very effective. However, there are some things to take into consideration when we think or talk about condoms. Proper use is paramount to their effectiveness. So I remember being in high school, and it was the thing for the boys to, always have a condom in their wallet. And I was not sexually active at that time, and I even had a condom in my wallet. For what reason, I have absolutely no idea. I just wanted to be cool, I guess. But what happens is we run the risk of that condom not being used until the time is right, prom 3 years later. So never being used and staying in the wallet or the back pocket of that person, okay? Body heat, body temperature, at the heat of the South in general, it's very hot out here. It breaks down the latex, it breaks down the lubrication that those condoms are made out of that make them efficient. Other things to think about. So in saying that, keep your condoms in a dry or cool area. All of the directions are on the box. The best place to keep them is in like a nightstand or somewhere in the house where there's a regulated temperature, and you don't open them, touch them really, or play with them too much, because you don't want to break the covering that they're in, the best word I can come up with just then. So only use them whenever you need to. Other things to consider when talking about condoms: check for an expiration date. So as I mentioned, condoms most of the time have some lubrication in them, and that lubrication prevents friction. And so therefore it prevents the tearing or ripping of the condom, and it prevents the tearing or ripping of the mucous membranes of the vaginal or anal canal, which we know are highly susceptible to transmission of HIV. So check the expiration date. They have one just like milk. And you also, if you grab a condom, I don't have one readily available. Usually I do. If you grab a condom and you pinch it right in the middle, an air bubble, not huge, but an air bubble should come up inside of the condom. And that means that the perforated edges have not been torn, or it has not been poked or sticked or tampered with. So we want to make sure we do that. Next, we have PrEP. And I will be talking about PrEP on the next slide, and it is 99% effective. And then we have treatment as prevention. We also call this TASP. And TASP can be most directly associated to U equals U, and that is 100% effective. And then we have PEP, which I will also talk about, and that is 80% effective. Okay, PrEP. Oh, I gotta speed things up. PrEP stands for pre-exposure prophylaxis. PrEP is an HIV prevention strategy where HIV negative individuals take an anti-HIV medication before coming into contact with HIV. We have Truvada, Descovy, and generic Truvada, and it is widely considered 99% effective in preventing HIV. If you're interested, you can, I'm no longer the PrEP navigator, this is an old slide, but I will definitely help navigate. You can reach out to me for absolutely anything. Essentially, PrEP is a once daily pill that prevents HIV if you are at high risk or susceptible to contracting HIV. And previously I mentioned PEP. PEP is post-exposure prophylaxis. And that is for individuals who have potentially or absolutely been exposed to HIV, and they don't know their partner's status. They don't know if that individual is undetectable, or if they if bodily fluids were shared. And so it's a preventative method that can be taken to ensure that you do not contract HIV from whatever sexual intercourse or injection drug use that you partook in, willingly or unwillingly. And I say that because our survivors of sexual assault are considered some of our main patients in prescribing and considering PEP, because it can prove to be extremely beneficial for their circumstance to ensure that they do not contract HIV from a situation that they did not even want to happen in the first place. And so PEP is 2 medications, and it has to be prescribed within 72 hours of exposure, so 3 days, and it's only taken for 28 days, and it will completely protect your body from contracting HIV from whatever interaction that was. So here are some myths about PrEP that we want to break down. PrEP is too expensive. No, it's not. Agencies like ours, Lifelines, AIDS Alabama South, Franklin Primary, Mobile County Health Department, and some other agencies, we have clinics and methods and funding. We have a lot of resources for everyone who is in need or deserving, which I believe everyone is deserving, to get the medication that they need, whether that's HIV treatment or prevention treatment. I'll have bad side effects from taking PrEP. That is a false statement. Previously, the previous cocktail, it did cause some renal issues and liver issues, and they've fixed that. It's all changed. We have other medications now. Actually, there is now Apretude, which is a once every 2 month injectable PrEP. So you just receive 1 injection. We have heard that PrEP users are, meaning that individuals who take PrEP are taking it because they know that they're going to have sex with a whole lot of people. That's not true. You do not always know your partner's truth unless you are having those openly healthy sexual conversations and you fully trust them and they trust you, and you're getting tested together and you're sharing that status openly. Then you don't know the truth about the individual that you are having sex with. Myth 4, you only take PrEP on days that you have sex. That's not true. It is suggested that you take PrEP every single day. However, there is a 2-2-1 method, or 2-2-1, where you take 2 pills. So say like I would take 2 pills on Sunday, and then I would take 2 pills on Monday, and then I would go to just taking 1 pill every day after that. And on that 3rd day, that 2-2-1, that 3rd day, I would be at the highest, safest efficiency of preventing HIV from entering my body. And then myth 5, PrEP is only needed for gay people. That is incorrect. We know very much so that HIV can affect absolutely anyone. Here are some other myths. In light of saving time, I will not go through them deeply, but PrEP makes condoms useless and obsolete. No, that is incorrect, because although you're taking PrEP, that prevents HIV, not STIs. So we still need the condoms to prevent STIs. If I start PrEP, I will have to take it for the rest of my life. You can start and stop whenever you like. Taking PrEP means that I will have to visit my healthcare provider often. No, 3 to 6 months is regular, is a regular time frame whenever you're taking PrEP, because we do need to take blood work and make sure the medication is working and make sure that you're maintaining that negative status, make sure you have not contracted any other STIs. Taking PrEP will make me test HIV positive. No. And then taking PrEP means that if I ever do become HIV positive, that medicines will not work for me. That's incorrect. Remember, there were a multitude of drug classes, and so you cannot build that resistance that way. Here's information on PEP. I already went deeply into this. There's a little bit more. And so who should get tested? Absolutely everyone. The CDC recommends everyone between the ages of 13 and 64 get tested at least once per year. And we offer a variety of tests. So we have antigen and antibody test, and that looks for HIV antibodies and antigens. The antigens are foreign substances that cause your immune system to activate if you are living with HIV. And an antigen called P24 is produced even before the antibodies develop. So tests that detect both the antigen and antibodies are recommended for testing done in labs and are now most common in the United States. We have simple and restricted antibody tests they protect the presence of those antibodies which HIV creates. And an initial HIV test is typically an antigen antibody test or simply an antibody test. If the initial HIV test is a rapid test and it is positive or preliminary positive, the individual will be sent to whatever healthcare provider that they prefer, or stay at our lab or our clinic or at Lifeline, wherever they need to receive blood work and follow-up testing. So here's a list of the tests that we offer. One is an oral swab. You can't have anything to eat 20 minutes before. And you literally just swab the lining above the gums on the teeth. And we get results in about 20 minutes or 15 minutes. And then we have the Alere determined HIV 1 and 2 antigen and antibody combo. That's a finger stick. It does not hurt. It's like checking your blood sugar. And we get those results in 20 minutes. And now the most recent test is the INSTI Biolytical HIV 1 and 2 antibody test. That is also a finger prick, and we get those results in 1 minute. You can come see us to get tested. You can look up AIDS Alabama South or Shell Health, SHELL, and you can find all of our information. And I am finally done. I have talked your heads off. I know I have. If you have any questions for me, I'd love to answer them.
No, that was absolutely great. And thank you so much for your transparency. Like, we can't thank you enough for that, for sharing your story. We know that there are several people, whether they commented or not in the chat or, on Facebook, we know that someone needed to hear that. Someone will start their healing journey because of that. So we greatly appreciate you for that. We did have a couple of comments in the chat. Holly, who is one of our co-workers, she said, thank you for letting us know the best terminology to use, that we need to hear that. Then she commented about the stats. She's like, those stats are horrific.
Yes.
So, I know that people know that it is still an issue, but I think when you put the stats with the information, I think it really sets a different tone. She also was talking about the disparity. She said huge disparity. And Tamika said, major thank you to Shay for sharing your story. So yes, absolutely.
Always.
Yes.
Thank you all. I appreciate that. And Tamika, I did get your request. I'm emailing you the PowerPoints right now. Kelsey, Chanel, would y'all like that as well?
Yes, please.
Cool.
Yes.
Got it.
And Holly sent us another comment. Great info, Shay. Thank you for sharing your story. So yeah, lots of thanks to you, Shay.
I appreciate y'all very much. Thank you for having me.
Yes, absolutely. It's our pleasure. And I see that Tamika has, she has had to exit, but we wanted to go ahead and close out. Ladies, did y'all have anything else before we close out? Either Ashley or Chanel?
Hey, I just want to thank you for your candor and just the work that you do and the support that you give us in this work because it's so new, and the information that you provide us and your willingness to help us help the community.
Yes, absolutely.
Always community first. Thank you all. Y'all are a wonderful partner.
And so in closing, if there is anyone who is live with us right now or who will be viewing this later, if you need to reach out about any of these services, Shay, what is your information for the people?
So you can reach me at my office number. You can text or fax to this number as well. It is 205-918-8224. My email is shay.thorn. So SHEY.THORN at AIDSalabama.org. And you can find me on our websites as well, or any of our staff at www.aidsalabama.south.org and www.shellhealth.org.
Awesome. Thank you so much. And if anyone needs to reach the EHE team at Lifeline's Counseling Services, our office number is 251-431-5100. We would love to hear from you. If you need any type of partnership, need us to come out for any outreach events, or just have questions. And if anyone that is live with us today or will be viewing this later is a victim or a survivor of sexual assault, just know that we have individuals here, advocates that are willing and able to help you throughout your journey. You have access to 24/7 advocacy. And so that number is 473-7273. And just remember, everyone, we see you. We support you. We are here for education, and we are always advocating for you. So until next time, everyone, take good care.